Welcome to the Preventive Medicine Podcast. Help us change the paradigm of medicine from keep people alive to help people thrive, one episode at a time. And now, here's the show.
Baraki, do you have a comment? I just didn't want to cut you off there.
Yeah,
and you look like you wanted to say something.
The same thing. I was gonna build that into the next part of this, where we were talking a lot about how we want to educate the patient, both from educate the patient and other physicians on the benefits and harms of screening and different ideas when it goes to preventive medicine in that regard. But you also touched on educating patients, which has to do with a lot of what Jason and I talk about, both amongst ourselves and with other guests, is that we want to build a resilient patient population where they have a high self-image or high self-efficacy of themselves, which is also what we talked about with our model of health. So with that, why is it so important that patients are educated and have a high self-efficacy? Like, why is it important to have a high narrative in a sense?
Yeah. So the narratives that we build around health and around various health conditions have enormous consequence downstream. And this is definitely something that is underappreciated across a lot of fields. I'll say if you're ending up in PM&R, that's one where this can be problematic in a lot of cases. Just pain medicine in general, it can be really problematic in this context. But yeah, I think you can look across just about every medical condition or every medical scenario, and there actually is an enormous body of evidence on the importance of self-efficacy and the association of it with better outcomes. When patients feel like they have the skills, the strategies, the knowledge, the ability to take care of themselves in various conditions, outcomes are going to be better compared to the opposite, which is more of a learned helplessness scenario. Medical dependence, things like that are situations that tend to result in much worse outcomes. So we definitely want to promote that to whatever extent is possible, and giving people things that they can feel more in control of to kind of guide their own, chart their own path throughout times of suffering, disease, things like that. But definitely, patients listen to us. They listen to us more than we think. It's easy to get jaded and say, this patient's never going to do what I tell them to do, even though that's not the way to go about this kind of conversation. But people listen to it. We are held in a position of authority more than we can appreciate in a lot of times. And on top of that, again, we took this oath to do no harm. We do systematically tend to overestimate our benefits and underestimate our harms. With respect to the things that we can do and offer to our patients. And one of the biggest places where we underestimate our harms is our use of language with people. The language we use around certain conditions itself can really set people up for success or failure. And I would not say that is an exaggeration or an overstatement based on a lot of the available evidence, particularly in the pain musculoskeletal rehabilitation world, where the language that's used when discussing certain patient conditions, it can set them up for a lifetime of disability, fear avoidance, behavior, kinesiophobia, things like that. On the other hand, more optimistic language and discussions of patients' conditions in a way that does tend to promote more of this self-efficacy, gives them a role to play in their own health, that tends to flip things in the other direction. People tend to have much better outcomes from this, even if their pain intensity, even if they continue to live with some degree of pain, we don't get their pain score to 0, because oftentimes that's an unrealistic target. They're able to live better in the face of that discomfort. They're able to engage with life, do the things they want to do, not lose their sense of self and autonomy as a human. And this extends not just in the pain rehabilitation world, but across a whole host of other situations as well. And there's ample evidence of this as well. Even, one example, when I'm talking about the pain conversation, like low back pain being as hugely prevalent as it is, there's even data on, just rewording radiology reports, right? Whereas instead of saying severe multi-level degenerative disc disease, right, saying age-related changes, when you're having the conversation about this with the patient itself, can change their whole conception of what's going on with themselves, whether they're fragile, whether they're about to walk outside and be paralyzed by turning the wrong way, or whether they can continue to move because that's kind of an expected finding, maybe in somebody who's 75 years old or something like that. So definitely an underappreciated thing. And when I am rounding with teams, and always getting them to sit down at the bedside and sit at the patient's eye level and have these kind of conversations with them, I'm listening just as intently to what the student or the intern or the resident is saying and how they're saying it as I am to what the patient's saying. And then we debrief after we leave the room to say, you noticed how you said this particular phrase. I would have said it this way. I would have explained it a little bit differently, et cetera, so that we can kind of nudge them in the right direction over time.
So with that being said, I think it's like you said, I think one of the things that patients take away from their visits to the doctor, whether for screening or for, symptomatic diagnosis, whatever, is a change in the view of self, right? So if you end up with, you come to the doctor with shortness of breath, whatever, the symptoms of heart failure, and you get diagnosed with heart failure, guess what? Your view of yourself just changed.
Yeah.
Because you went from, well, I thought I was a healthy 50-something-year-old person to now I carry this big diagnosis that sounds scary and has probably large implications on my not only quantity of life, but my quality of life. So I think in terms of screening and the terms and diagnosis we give people, we need to be very careful about what impact that's going to put on how they view themselves. But saying that, do you think that a person's narrative of themselves can in a way be preventive? If I think, well, I'm a pretty resilient person, I can handle a lot. Do you think that's something that actually goes into preventive medicine in terms of the way a person views themselves and their health? Or is that kind of just a little bit wishy-washy?
I see examples of that pretty frequently, where people's narratives, self-concept, their self-efficacy, things like that can influence their own subsequent behaviors, their degree to which they end up using the healthcare system, and therefore the degree to which they're exposed to the risks of the healthcare system, right? So, in my coaching side of things, when I'm coaching athletes and things like that, very frequently nowadays, after I've been coaching people, I have several people I've been coaching for 7 or 8 years. And one of them might tell me, oh yeah, I tweaked my back 2 or 3 weeks ago. It happened. I was having pretty severe back pain for a few days, but I knew what to do. I knew how to take care of it. And I just didn't bother telling you. I just fixed it myself. And now here we are. So we're back on track. And I'm like, that is amazing. That is awesome. That makes my day, versus a situation where it's a very different situation when I have somebody who says, I tweaked my back. I was worried that I was going to be paralyzed. So I went to an ER. I underwent a stat MRI for my acute nonspecific low back pain. And then, they consulted a surgeon who told me I was going to need to get a spine surgery within the next 5 years if I don't stop lifting or something like that. Right. So those are two drastically different scenarios. And the two different ways that this plays out can have huge implications. On one hand, I have somebody who is high degree of self-efficacy, high degree of confidence in their ability to self-manage this condition. And they took care of it in normal, kind of the normal natural history of acute nonspecific low back pain, for example, resolving in a couple of weeks, compared to the other person who not only did they not have that confidence, they had a lot of fear, anxiety about the issue. They pursued the immediate medical evaluation, which itself is not inherently bad, right? If you don't know what to do, it's okay to do that. But then that's when they get exposed to the harms of the medical system, potentially if you're seeing people who don't necessarily know how to manage this condition in an evidence-based fashion. Of course, if you show up to an ER, their rule 100% sensitivity for bad things. I'm going to try to find anything that's bad. But then at the same time, how do you have the conversation with the patient when you don't find anything that's bad? And that's what can then alter their life trajectory. Maybe they're like, oh, I can never lift anything again because I had back pain once. That has huge implications, because now automatically they're no longer able to meet current physical activity guidelines because they can't do resistance training, from their own perspective. Now they no longer feel they can do that. And maybe because they feel like they can't do that, then they self-select for a decreased level of physical activity. They might gain some weight. They might develop sleep apnea. They might develop fatty liver, cardiovascular disease. They might develop all kinds of medical downstream complications that were, if you back up, attributable to the narratives that they had about things that they experienced. I see this actually quite commonly in some of the military population that we see. People who get out and maybe they have some back pain and they're told that they have disc degeneration and so they can't exercise, quote unquote. And then later on, you're seeing them in the in the cardiology clinic for their AFib that's due to sleep apnea. You're seeing them in the hepatology clinic for their fatty liver disease. You're seeing them in various other places developing these medical complications that were, when you look back, potentially avoidable through some of this stuff, because maybe the condition that they were told they had was not a contraindication to ongoing activity, but the way that it was framed and explained to them painted it as such. And that's just an example of an underappreciated harm of the language and the narratives that we use around this stuff.
Yeah, you straight up like took the words right out of my mouth as the downward spiral, as you were describing as a patient, that they get told something or they have a very minor injury. And next thing you know, they're like, all right, I can't squat anymore. I can't do any exercise anymore. Otherwise, I'm going to break my knee. I'm going to pop open my disc in my lower back, whatever happens. And then a lot of times it's that downward spiral. If they don't exercise, they get scared to exercise. And then whatever intensity they used to have in their exercises completely thrown out the window. So it's definitely a difficult line. And it's also a very narrow line between when a patient has a very high self-efficacy, or if they're like right on the line of like that higher self-efficacy and lower, where they could easily become a very medicalized patient, or they could be like a resilient patient, as we're talking about. And Jason and I are both of the mindset of that. We think preventive medicine is a lot about setting the patient up for success so that they can do a lot of things themselves and not necessarily need the healthcare system. Obviously, the healthcare system is great at what it does in certain aspects, but as you're talking about, it also can do a lot of harm. So we want to have that balance where the patient is able to do a lot for themselves and be able to utilize the healthcare system when needed. And a lot of that comes with having that positive self-image. If they're able to build that up through like over time of like little wins, is what I talk about. A lot of little wins together. They have a high self-image and they can kind of figure things out for themselves and know when to use a healthcare system versus kind of just relying on it and then reading those billboards and saying, oh, maybe I should get this full body MRI.
Yeah. One way that I've seen this discussed that I really liked was the idea of, you may be familiar with the idea of universal precautions, like in the hospital with respect to, hand washing and hygiene and things like that. And so one example would be, let's say somebody shows up with an acute pain related issue, just applying universal precautions to everybody that you see in that scenario, in the sense of treating them as if they are somebody who can progress to like a persistent debilitating pain state. In other words, doing everything you can to avert that clinical trajectory early on, rather than just treating them, maybe blowing the issue off or something. And then if they do end up progressing, then you're in a much deeper hole to try to dig yourself out of with that person. So universal precautions with respect to treating everybody as if they could progress to being more dependent on the healthcare system, and doing what you can to avert that earlier on is probably a good move.
Preventive medicine is an incredibly important topic. I want to thank you for taking the time to watch this video. For the full episode, find us on your favorite podcast streaming platform. If you enjoyed this video, don't hesitate to hit that subscribe button, like this video, and share it to keep that message spreading. Thank you once again for watching this video, and we'll see you in the next one.